The topic I'm going to talk to you about today is treatment recommendations. To that end, I've brought the 2022 EULAR guidelines and the 2017 SEER clinical practice guidelines, which we'll be reviewing in a somewhat cross-sectional manner. Regarding the general principles of treatment, as we already know, it should be aimed at controlling inflammation, structural damage, and disease comorbidities. And the therapeutic strategy is based on two fundamental aspects. On one hand, early treatment with DMARDs, which is related to the concept of a window of opportunity. This refers to the period during which the disease is likely to respond well to any treatment. This window is generally considered to fall between weeks 15 and 20 from the onset of symptoms. On the other hand, there's the concept of treat the target, which involves aiming for a therapeutic goal that ideally would be sustained remission. Alternatively, achieving low disease activity with frequent follow-up visits until that goal is reached. General recommendations include lifestyle habits that we all already know, quitting smoking, engaging in physical activity, avoiding obesity, and managing periodontal disease. Here I've brought you the 2022 EULAR recommendations, this treatment algorithm, which refers to phase 1 of initial pharmacological treatment. What it tells us is that when a patient is diagnosed with rheumatoid arthritis, treatment should be started as soon as possible after diagnosis. The first-line treatment would be methotrexate, and if there is a contraindication to methotrexate, treatment could be started with leflunomide or sulfasalazine. Additionally, at this point, we would need to assess the need in a second step to add corticosteroids for the short term at a certain dose, a somewhat variable dose, depending on the patient we have, but always with the intention of reducing the dose and discontinuing corticosteroids as soon as possible. Furthermore, it tells us that initially we should schedule frequent visits every 1 to 3 months until we reach the point we need to evaluate. And if we have reached the goal at 6 months, or if there has at least been some improvement by 3 months, if that is the case, when the patient is in sustained remission, the idea is to reduce the dose, and if that is not achieved, the treatment should be modified. Now we're going to look at what the 2017 SER clinical practice guidelines say about this initial treatment phase. They make several recommendations. The first one talks about the dose of glucocorticoids to start, and they recommend doses between 10 and 30 milligrams per day as initial therapy in combination with DMARDs, always with the intention of gradually reducing the dose. The next recommendation discusses triple therapy, and although it says that it is not the first-line treatment, it could be considered as an option for patients who have contraindications to the use of glucocorticoids. Returning to recommendations, EULAR, the next phase, which would be the treatment of the patient resistant to conventional starvation, tells us that a patient, when a conventional starvation fails, we have to consider whether or not they have factors for a poor prognosis. What would be the poor prognostic factors? Well, the presence of a positive rheumatoid factor, high titers of anti-citrulinated peptide antibodies, and high disease activity. Early structural damage or failure of 2 or more DMARDs. So if there are no poor prognostic factors, the recommendation is either to switch to another conventional DMARD or to add another conventional DMARD. And if the patient has poor prognostic factors, the recommendation is to add a biologic or a JAK inhibitor, depending somewhat on the patient's characteristics, also taking into account cardiovascular risk and comorbidities. And again, we should schedule frequent visits, assessing whether the therapeutic goal is achieved at 6 months or if there is improvement at 3 months. And based on that, either reduce the dose or increase the treatment interval, which would be another option. Or if the goal is not achieved, then we should continue adjusting the treatment. Well, the clinical practice guideline recommendations regarding this phase, which is probably the most controversial because it addresses when to start biological treatment and which biologic to initiate, they make several recommendations. This goes somewhat along the same lines as what EULAR stated, which is that a patient who fails methotrexate monotherapy could start combination therapy either with a conventional DMARD or with a biological DMARD, depending somewhat on the patient's characteristics. So what it tells us is that the treatment of choice would be biological therapy. However, in patients who do not have poor prognostic factors, and especially considering the economic impact, it may be worth considering combination therapy with conventional DMARDs. In the next recommendation, a patient failing conventional DMARDs should start biological or targeted synthetic DMARDs. What they discuss after reviewing the literature is that no major differences exist in terms of effectiveness when comparing targeted synthetic DMARDs with biological DMARDs or even among biological DMARDs themselves. Among them, however, due to the experience with their use, a slight preference is still given. To anti-TNFs, another thing we need to take into account is the convenience of the oral route, especially in terms of adherence, but it shouldn't be the main factor guiding treatment decisions. And then in terms of safety, what the data suggests is that the adverse reactions of targeted synthetic DMARDs are generally in line with those of biological DMARDs, with some differences but minor ones, which might make closer monitoring necessary. Initially, but overall, they do not differ substantially. So the recommendation is left somewhat open, suggesting that biological treatment with targeted therapy could be initiated depending somewhat on the patient's characteristics. The next point is that for patients who are indicated for biological treatment but have a contraindication or intolerance to methotrexate, the recommendation is to use leflunomide. So here they do mention that biological agents have greater efficacy and survival when combined with methotrexate. However, if methotrexate cannot be used due to contraindication or intolerance, they recommend leflunomide. Above all, they recommend it because of its simple method of administration, good tolerability, and because it has been extensively studied in combination with biologicals. Here, what they are trying to address is the question of what the optimal starting dose of methotrexate should be when it's combined with anti-TNF or another biological agent. And what they say is that there is some uncertainty around this. The recommendation is to start treatment with at least 10 milligrams per week, but as I mentioned, there is some uncertainty about the exact dose. The next recommendation tries to address the big question of which biologic DMARD to choose. And what it tells us is that when combined with methotrexate, it is not possible to recommend one biologic agent over another. However, when treatment is given as monotherapy, there are studies that have shown the superiority of anti-interleukin agents, IL-6 inhibitors over anti-TNF agents, but ultimately it has to be an individualized decision based on the patient's characteristics, medical history, comorbidities, and of course the patient's preferences. In this recommendation, what they did was compare the efficacy of a conventional DMARD in monotherapy versus a biologic DMARD in monotherapy, versus a targeted synthetic DMARD in monotherapy. So what they tell us is that there are no trials comparing JAK inhibitors in monotherapy with biologics in monotherapy. Therefore, there is no data. What there is data on, however, is the comparison of the efficacy of JAK inhibitors in monotherapy versus methotrexate in patients with rheumatoid arthritis, of recent onset, meaning less than 2 years of progression and who have not previously received DMARDs. But this is not applicable to our healthcare system, as the use of JAK inhibitors in this case is off-label in our setting. Therefore, the recommendation is left for patients for whom conventional DMARDs cannot be used and who require monotherapy treatment. JAK inhibitors would be an appropriate option. Going back a bit to the recommendation EULAR in this final phase, which is the treatment of the patient who fails the first biologic, what they tell us here is that a change should be made, either the biologic or to a JAK inhibitor, depending somewhat on the characteristics of the patient. Again, frequent visits would be necessary to assess whether the treatment goal or improvement is being achieved in order to reduce the dose, increase the interval, or if not, continue adjusting the treatment until the goal is reached. The clinical practice guidelines for this phase tell us, well, we touched on this a bit yesterday. If a patient fails an anti-TNF, do we give them another anti-TNF or switch to a different mechanism of action? So, well, what they say is that switching to a second anti-TNF is an acceptable option, since anti-TNFs have different molecular structures and different affinities for tumor necrosis factor alpha. And then a bit of what we discussed yesterday, that often failure of an anti-TNF is due to antibodies against that specific anti-TNF. Therefore, failing a first anti-TNF doesn't mean you're going to fail a second one. However, obviously, switching to a different target is also a logical and acceptable option. So regarding this, scientific societies have not established a recommendation because there is no conclusive data. And the recommendation is left somewhat open, as in you can either use a second anti-TNF or switch to another target, somewhat depending on the type of inefficacy and the characteristics of the patient. And this recommendation tells us that if a patient fails treatment with a biological drug, we either give them another biologic or a targeted synthetic DMARD. So what they're saying here is that there is a lack of head-to-head comparative studies between targeted synthetic DMARDs and biological DMARDs, so no drug can be prioritized over the others, and it has to be an individualized decision. And just to wrap up, the management of rheumatoid arthritis, as we already know, must be a comprehensive approach that covers various aspects, including nutritional dietary counseling, physical exercise, adequate rest, psychosocial interventions, and health education. Therefore, it is necessary for a multidisciplinary team to be involved, with different healthcare professionals participating. And also it's important to consider other techniques that could help in the proper management of the patient, such as rehabilitation, physical therapy, and intra-articular corticosteroid treatment.